we'll get going here today. So welcome to the September board meeting of the Spokane Regional Health District. We'll go ahead and call the meeting officially to order. Our chair, Brian, is going to be a little late, so he asked me to go ahead and get started. And we'll go ahead and start with our roll call. So we'll just go ahead and do introductions.
Karen Mary Cuney, Spokane County Commissioner.
Andrea Prostad, Michelle Fossum, Legal Counsel.
Josh Kearns, Spokane County Commissioner.
Linda Thompson, City of Spokane Valley.
Don Condon.
Bob Lutz, Health Officer.
Ray Byrne, Interim Administrator and Environmental Public Health Division Director.
Amelia Clark, Administrative Officer.
And Ben Wick from the City of Spokane Valley. All right, going down next, we'll have our citizen input. And I know I typically do the timing. Do you have a timer? You lost your other phone?
Yeah. So let me see this one.
Mary, do you have a timer? All right, so we'll let Mary.
Okay.
All right, so Mary will be holding up our 1 minute warning, 30-second warning. Time is up. And first that has signed in is Jackie Gallion.
Hello, Jacqueline Gallion, City of Spokane Valley. To public health employees, we understand you are in a difficult position because you have to follow the policy recommendations of the governmental organizations above you. But your continued public messaging that is based on faulty or out-of-date science is causing unspeakable amounts of harm. Our children are becoming sicker and sicker because your focus on infectious disease at the expense of the exploding rates of chronic disease is not a viable or sustainable option. Our children must not be collateral damage in the war you've waged against microorganisms. And your misleading public messaging about the capabilities and limitations of vaccine products have created a society of people wielding their torches and pitchforks, who feel comfortable dehumanizing those who have suffered at the hands of vaccines and who are daring to criticize aspects of the vaccine program. You have lumped us into one simple yet untrue umbrella of anti-vaxxers, when, in truth, we want vaccine safety science to be cleaned up so that vaccines are safer for everyone who takes them. This is what the 1986 National Childhood Vaccine Injury Act required by law, that vaccines be made safer. That requirement has been blatantly ignored. And while HHS continues to ignore their obligation to vaccine safety science, you continue to ignore our attempts to engage you in the latest science that calls for a change of policy. In refusing to acknowledge the new science and the missing science in favor of pharmaceutically driven status quo policies, you have inspired us to take our message directly to the people. You have actually given us a gift. Unlike public health employees, the individuals we engage with are appalled by the data we show them and your refusal to acknowledge it. This is why the number of people criticizing vaccine products and policy are growing, despite your attempts to snuff it out and mislabel us as anti-vaccination movement. You in public health are spinning your wheels trying to convince people that vaccines are safe. We don't have to convince anyone of anything. We simply show them the data from the CDC and all sorts of mainstream sources, and we study and I lost my spot. And we show them what has not been studied, what questions have not been answered, what science has not proven, and they are appalled. Anyone who has the truth and the science on their side will have an easy time making their case. And when enough people have heard this information and connect it to the harm they are seeing in their own lives and their children's lives, they will stop buying this broken, failed system of public health and corrupt alliance of pharma and state, and they will force a change in the vaccine policy that are harming so many. And we will continue to grow. We will continue to educate the public, and we will continue to work towards restoring our children's health. Thank you. I also want to add that we are still requesting our roundtable discussion with public health and being made an agenda item here at this meeting. So thank you.
sorry, please no public outbursts. And we're gonna move on to, and I forgot to remind people, it's a 3-minute time for speaking today. And our next person is Ina Merrill. Hopefully I get your name correctly.
My name is Ina Mayorov and I'm with Spokane County. My topic today is to explain to you where the vaccine hesitancy is coming from. You are creating it by acting as a handmaid to an out-of-control, morally and legally corrupt pharmaceutical industry that has been found guilty of felony, fraud, bribery, and causing the death of tens of thousands of U.S. citizens. You are creating it by not having the intellectual capacity to understand that an industry which is happy to sell fatally defective and misrepresented conventional drugs to children will act the same way for their biologic products named vaccines. You are creating it when you say, look, we all hate the pharmaceutical industry, but vaccines are different. They would not act the same way about vaccines. Really? What is the moral difference between killing a child with an opiate and doing so with a vaccine? This is absolutely no such thing as one size fits all with vaccines. Newborns have 20% of a kidney function of a 2-year-old, yet both receive the same dose of aluminum-containing vaccines. The one size fits all approach is in stark contrast to precision medicine, an emerging approach for disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each person. You create it when you say, yes, in theory, someone could be injured by a vaccine, but then deny every vaccine injury claim you hear without any consideration at all. You have had dozens of sane, rational, well-educated people who explain how they were trying to comply with the vaccine schedule until they experienced or witnessed an undeniable injury. I'm one of those people. Keep in mind that the number of those people will continue to increase. These people were not anti-vaccine. Remember, anti-vaccine people do not use vaccines. You create vaccine hesitancy by recommending that pregnant women who don't smoke, drink coffee or alcohol or eat seafood to receive vaccines that the FDA was forced to admit in court have never been tested in pregnant women. At Pig Out and Park, I was part of the informational group. A young couple came forward to share that they complied with gestational vaccine recommendation and their perfectly healthy fetus was killed by vaccines. This couple will never accept another vaccine for themselves, had not vaccinated their subsequent child, will not vaccinate any future children, and will advise anyone who will listen to them that vaccines are not always safe and effective, but might cause death. Save your money trying to figure it out. We're here every month trying to tell you. Why is it so hard to believe that the same industry that gives us the opioid epidemic could be lying about vaccines, especially because they can be sued and forced to tell the truth?
I'm sorry, your
Thank
time
you
is
so
up.
much.
Thank you. Just want to acknowledge that Mayor Freeman from Millwood has joined us, and so is our chair. Oh, continue on. We just have one more for citizen input, Rosemary Waldron.
I'm Rosemary Waldron. I formerly lived in Spokane a number of years, beginning in 1977. I lived here earlier in the 40s when I was a child. I was born in the 30s, and prior to stopping the receipt of vaccines and their boosters, which was in 1966, I was chronically ill. It was determined as a subsequence of the vaccine reaction, the adverse reaction that I had in 1966, that I was allergic to one of its chief constituents, which was legally not required to be labeled, and that was fluoride in its various compound forms. I say amen to everything that you've just heard from the two previous people who gave you information. I am trusting, and I've told this group, although some of you are not a member, I've been going here, I think I started in 1997. So I've been attending these meetings ever since, giving information to enlarge the general frame of reference, because the problem that we have today is an absence of the wisdom of history and a deliberate or inadvertent ignorance. And ignorant people are easily manipulated by fear and special interests.
Thank you. Moving on to our consent agenda. Is there anything anybody would like to set aside from the consent agenda? Seeing none, do I have a motion for approval of the consent agenda?
All right, thank you. I move to approve the consent agenda.
Second.
All right, any further discussion on the consent agenda? Seeing none, all those in favor, please signify by saying aye.
Aye.
All those opposed, same sign. Consent agenda is approved. And I know that we've heard from some that have to leave early, so we're going to go ahead and move up the executive session to now.
All right. Well, thanks, Vice Chair Wick, for taking over for me at the beginning, and Councilmember Stratton and I both have to leave early as well, so this is my very short appearance, but it gives me great pleasure to officially welcome our new administrator, Amelia Clark, to everyone. Thank you. A lot of people were very happy to have an administrator, and then we were really happy once we got to know you, and you've already been meeting with people all over the community and the staff even before we were paying you. So thank you for doing that, and I think I speak on behalf of the board. We're really excited to have you and to move forward together. So thanks. Secondly, we got notice a little bit earlier this month that one of our board members, Dr. Condon, has accepted another very robust volunteer opportunity and is going to be leaving the board so he can address that. And Dr. Condon, if you could just please come up here for a moment. We have a certificate of appreciation for you and a donation to the Vanessa Behan Nursery in honor of your service, and I really appreciated your well-grounded and calm approach to public health with us, and you've made us smarter and more effective. So thank you very much.
Thank you.
And then I also wanted to invite Ray Byrne up, because much to his joy, this is his last meeting where he came in as the interim executive, the interim administrator on it. And for those of you who have been on the board and staff know that we have worked very smoothly without an administrator, a formal permanent administrator for the last year. And I know Ray has been on the phone to me many times, and I get just a glimpse of all the chaos that finds its way to the administrator's desk. And especially, I can speak, having been an interim director before, it's even tougher because people kind of know you're only the interim, so they push things a little farther, and you also wonder a little bit what's going to happen. So you have, I hope, kept your blood pressure down on the inside. On the outside, you've been a calm, steadying force and moved us forward. And for that, we would like to present you with a plaque. I'm here for the photo. Thank you. And with that, I'm going to turn it over to Mr. Wick.
Oh, we're on to the Board of Health Committee reports. Budget and Finance Committee, did they meet?
I was not here, so sorry now. Yeah, when we get to the finance report. Yeah.
Okay. Education and Communication? Do we need to-
We have not met, but I believe we will start up late October
Then policy committee. I know Kate's not here. Anybody that was on that one? We're just sailing through these committee reports. All right. Did I miss any committees that we know of? I think that's all that we had. So we're up to our administrative officer report.
Do I just press it to start? It's, oh. Here we go. Okay, well, thank you all. I'm very pleased to be here and starting my new role. Since it's only day 9, my report's going to be short and sweet as to what has been going on since I've been here. Like I had mentioned when I accepted the position, I really wanted to come in through the regular onboarding process so that I could really understand what that first impression is that we have for employees and of the organization. I did that on Monday, September 16th, and have hit the ground running in what I'm calling my listening tour of meeting with staff and different committees just to learn more about all the great work that we're doing. I've completed all the annual trainings related to holding this position, HIPAA, bloodborne pathogens, all the legal requirements. I've met with the chair and vice chair. We've also had executive committee of the Board of Health. In terms of relationship building, which I really want to focus on in my first 6 months, presented at the annual staff meeting, which is a great opportunity for all staff of the district to come together to learn more about what we're doing. I think that's something that really stands out to me about the district, that we take the time to focus on professional development of staff. And they got to learn a little bit about me during that. Started executive leadership team meetings and also facilitating those meetings, not just attending them, but facilitating them. One-on-one meetings with executive leadership staff and team. And Ian is helping me get one-on-one meetings set up with all board members, and I've already done a couple of those. Some of the upcoming focus, Ray already mentioned, or Mike already mentioned about budget education and preparation. We're in the midst of doing all of that, and that is really drinking water from a fire hose to start budget meetings on your second week. That's a great way to learn. I'm continuing my introductory meetings and continuing those meetings with executive leadership and managers. So, if anyone has any questions.
So if you haven't received a call from Amelia for a meeting yet, you're going to be.
You will be. You will be.
All right. Well, thank you, Amelia. Ray, anything that you wanted to add as the other part of the month?
No official report. Just wanted to welcome Amelia and say we're excited too.
All right. Health officer report, Dr. Letts. Yeah.
Because I always struggle with this.
Chair, I just wanted to say, we do have to leave, but I wanted to just thank ahead of time Dr. Letts for getting us that presentation on homelessness issues. And I'm sorry that I'm not going to get it, but I have connected with you offline. So I'm really looking forward to that we're going to hear it as a board. Sorry that I'm not going to be here for it. So we're on our way.
Good afternoon. Well, the two topics I want to talk about today are the ongoing hepatitis A outbreak and then what you've probably heard about in the news called severe pulmonary syndrome that's been associated with vaping. So I've been talking about the hepatitis A outbreak for a couple of months. It unfortunately is ongoing. As of when I printed up this slide, we had 23. As of this morning, we're up to 24 cases. This kind of gives you the background information of each of those individuals. You know, it's unfortunately not slowing down like we would hope. You can see by this epi slide that we actually have had an uptick over the months of August and September. Of note, every individual has been living in a homeless situation and has been using substances. So our concerns right now are that with the issues around homelessness, with the pending winter months and warming shelters, we may see this slow burn of an outbreak actually start to pick up a little bit. Of note that the state reported, I think the state will be calling this a statewide outbreak within the next couple of days, because we're also seeing increased number of cases in King County. So what we've been doing internally, ICS stands for an Incident Command System. This essentially is a means by which we as an organization can internally coordinate across a couple of different divisions, different departments, but also, if necessary, work with outside agencies to provide sort of a strategic approach. So we've been doing that. We've been meeting around hepatitis A for a number of weeks on a weekly basis. We've sent out a number of provider alerts, updating them on the signs and symptoms, what to look for. And again, I think that if you're not looking for it, you're not going to see it. Unfortunately, oftentimes people, when they present with hepatitis A, as we've talked about, they're presenting far enough along that they're jaundiced, which is kind of a big red flag. But I think importantly, what we're trying to get providers to realize is that if individuals meet certain risk criteria, i.e. they may be homeless, they may have a history of substance usage, then you may want to try to check for them earlier than later. Because again, if we can identify them earlier in their course, then maybe we can be a little bit more aggressive with how we manage it, and or also trying to improve our investigations. We've done a number of site visits between the EPI team, between environmental public health, going out and looking at kitchens. We've done a lot of different site visits, also going to the shelters. Importantly, we're looking at vaccinations, and I think this number is really impressive and it really stands out. We've had almost 40 clinics over the last couple of months. And this is just a couple of individuals working with nursing students, what have you, going out, going to the shelters, going to the kitchens, going to a variety of venues to provide vaccines. Because we know that if we can get individuals vaccinated for hepatitis A, it is very effective at preventing the infection. We've also, as Brian sort of alluded to, we've been in front of City Council. I've worked with the City of Spokane to make them aware of the issue and how we can be collaborating going forward. Any questions on hepatitis A?
Maybe for those cities that are maybe smaller, I know there's a lot of different cities, maybe we could get just like an email in brief or something of that nature to kind of pass out to the rest of our councils. Would be
happy to do so. Okay.
Where is it coming from?
Yeah, we believe, and Lindy, I might look to you for confirmation. My belief, Dr. Condon, is that the very first case came into Spokane but was probably acquired out of state. And since that time, all of our cases have been locally acquired. We have one case of hepatitis A, which is not part of this investigation, which is sort of an outlier, but everybody else has been sort of locally infected. Then briefly about this, again, this has been a big media concern and hype. For many of us, we've been waiting for something like this to happen because we knew it was going to eventually occur. You know, to think that vaping is a safe alternative to tobacco products is, again, a misleading statement. And we're now seeing that vaping is associated with what's being referred to right now as severe pulmonary syndrome. The CDC has been monitoring this, and as of last week, they had 530 either probable or confirmed cases across 38 states, with 7 deaths. The majority of individuals have been men. Again, you can see the age demographic. And the question that we still have is what exactly about vaping is causing the syndrome? The majority of individuals that the CDC have confirmed have used THC. Many of them have also used THC and nicotine. A significant number have used nicotine alone. So again, it's kind of difficult. There's been no consistency of product or instrument other than the fact that everyone has been vaping. Our message is that vaping is unsafe. We're specifically targeting our messaging towards young people because, again, demographically, that's who has been most oftentimes affected by the syndrome, although we have seen individuals in their 50s. We also are really focusing on pregnant women, women who are breastfeeding. These are, again, the demographics of greatest concern, but again, the bottom line is vaping is unsafe. That's our take-home message. Washington State As of today, we have 7 cases. This is the age group. And again, it's consistent with national data. We still do not exactly know what is causing the syndrome. So with respect to what we've done, again, similarly, we've established our incident command system, meeting on a weekly basis. We had a meeting this morning, for example. We're also been collaborating with DOH on weekly phone calls. We've been involved with case investigations, and this is kind of interesting. We now have access to a data source called Rhino or Essence. This is syndromic surveillance. So one of the challenges that we oftentimes have when we're looking at data is that we're looking retrospectively. In contrast, now that we have the syndromic surveillance where we have data coming from the emergency room, we can be looking at data that are in like real time, which is pretty impressive. So how we got started on our investigation, we actually have investigated a number of cases with 2 confirmed cases in Spokane County, was that we were contacted by DOH. They had gone into the Essence platform, had seen, again, individuals who met the CDC case definition of possibility. And so they were asked us to take a look at them. And so through our communicable disease epidemiology team, in conjunction with one of our staff who runs this sort of Essence platform, we did a deep dive into their records to look to see if they met the criteria. 2 of the 4 that we were originally asked to look at did meet those criteria. And so as I said, they now meet the state case definition. So coordination, provider alerts, the same thing we've been doing with hepatitis A, and it's been interesting and also very reaffirming to hear back from chief medical officers and other providers that they are now really looking for vaping. You know, I will argue that unfortunately in the past we ask about tobacco usage, we sometimes ask about vaping, but we don't ask for it regularly. Now I think the take home is that in many acute situations they are looking and asking for this. We've given a number of media, both I as well as staff from the health promotions team, where we have a very strong vaping and tobacco cessation program. We've been giving a number of media reports, and then again, really trying to improve and increase outreach and education across the community. Question, yeah. Thank you. Yeah, the question is specifically around whether or not anything is different coming off the street. And again, what we've seen is that there's no consistency, that indeed some of the products are bought, some of them are purchased in vape shops. What I've come to learn is that vape shops oftentimes manufacture their own solutions. So whereas you might think that if you go into a vape shop and they're purchasing their e-juice, as it's referred to, from a central place, what we learned, and again, we had an in-service this past week from one of the staff, they're concocting these e-juices back behind the counter, back in their little kitchen with a refrigerator, and oftentimes just sort of eyeballing the ingredients. So to truly say that what is in the product is sort of known, it's not at all. Unfortunately, what we are finding also is that many of these products, I mean, back when I started looking into this, we called them e-cigarettes. Now, as I said, the devices look anything but like a cigarette. And so these devices can be manipulated, can be altered, and people are making their own solutions. So oftentimes they're adulterating the solutions that they buy with other product, with other ingredients, and that's again potentially where some of the issues are coming up from.
So some of the media coverage on this is kind of would lead someone to believe that these are sort of the first cases that we've seen of this, but people have been vaping and using the e-cigarettes for years. Is this just the first actual kind of large scale that have people been getting sick from vaping in the past? This is just the first it's actually being covered in the media, or first real documentation of it?
I'd probably say more so the latter, Commissioner.
Okay.
I think that we can look retrospectively, and I think that's part of one of the challenges. I think we have not probably historically been asking about vaping as often and religiously as we should. And as such, people who have been admitted maybe for what's in medicine we refer to as acute respiratory distress syndrome. Sometimes we can find infectious causes, oftentimes we can't. And if we can't, then we chalk it up to an unknown. It's very possible that these unknowns could have been caused by vaping. But again, I think when I look at this, this is one of those great examples of how a couple of astute physicians put 2 and 2 together and got 4. They said, you know what, I just saw this. You know what, I saw a similar case last week. Oh, I saw another similar case. And by connecting all those dots, they were able to find a common denominator, that being vaping. Again, I think that this is but the tip of the iceberg, because I think we're going to continue to have more of these issues.
Can I say something?
Please.
The other thing is what we're learning is that these contents are contaminated and not guaranteed or pure. Am I on or off? Okay. I just finished a continuing education for aviation medical examiners that's put on by the FAA. And they have discovered that CBD oil, in fact, does have THC in it, and often is not contaminated. So, although that is also presented as just, benign, mentally altering, and that's not true. That's not true. So, I think we need to be very cognizant of the fact that not only maybe store to store, but product to product, the controls don't seem to be there for the purity of what they're claiming.
Any additional questions? Then just 2 final pieces, then if I may. Councilmember Wick asked at our executive committee about the quality of life survey. And just to let you know a little bit about that, this is our 3rd iteration of that. Begun back in 2015, we do a much more robust survey every 4 years, that being this year and 2015. We had a smaller survey done back in 2017. It will be finishing up this month. To date, we have received 2,300 paper returns, 1,200 online. We mailed out about 14,000, of which 10,000 were either delivered or accepted. And so our response rate is about 30 to 35%, which is sort of typical of what we've seen in the past. Our preliminary data will be presented in a few months, and then we'll be rolling those out as well later on. So, and then finally also, Councilmember Wick asked about the domestic violence video that he had heard being presented, and I'm going to ask Jen Hansen to come forward and talk a little bit about that.
Hi, you may remember me. I was here a few months ago talking about an initiative, Handle with Care, and I'm really happy to report that that initiative is on track for implementation for January 2020. So I just wanted to give you an update about that. But the reason I'm here today is to tell you about the community effort happening in Spokane. And in fact, I would really be surprised if you weren't aware of it because well, if you read the spokesman, it was on the, the front page today, I believe. And it's really exciting. Private, nonprofit, and governmental organizations are coming together to highlight domestic violence in our community. And you may remember from the violence report that was produced from the Spokane Regional Health District Status Center that Spokane's domestic violence rates are really high. They're higher than the state average, and domestic violence calls are the most frequent and the most dangerous calls that our law enforcement respond to. And the really sad thing is that we know that our numbers are high, but the likelihood is that they are much, much higher than what we're capturing because domestic violence is often shrouded in shame and secrecy. And we really need to change this. So on Monday, September 30th, you are all invited to the Bing at 7 o'clock, if you're interested, to attend a showing of a local documentary called Ending the Violence. And this documentary has been created with support from multiple entities, all volunteer. There are multiple SRHD staff members highlighted in the documentary, and you will be very, very proud of the staff here. The public health nurses do such a wonderful job of representing the complexities of domestic violence, as well as Stacy Wenzel from the data center just did a phenomenal job talking about the horrific stats about this. The documentary is really well done. I was able to see a preview before it was completely finished. And people who watch it will walk away understanding the complexities of domestic violence and maybe a clear understanding of why victims don't, just leave, as we often hear. And so if you're unable to attend, or if you're not interested in attending at the Bing and want to watch from your house, or elsewhere, it's really exciting. Almost every single news station in Spokane will be airing this documentary at 7 o'clock on September 30th. So if you turn on your TV, it will be there. And this is the first step really to shining the light on the local problem of domestic violence, but then also to get the conversation started. And so, so let's get talking about it. Do you have any questions to that?
No, I just knew it was on our strategic plan as one of our major initiatives, so I just wanted to make sure that we had some comment here. There were some at the Visit Spokane board that I was on to kind of talk a little bit about it. So.
Yes, and I represent the agency on the Domestic Violence Coalition, and so they are currently in the process of becoming a 501c3 and having a more formal structure to the coalition, but I can say that it is one of my favorite meetings to attend each month because there is such a wide variety of people at the table. You have judges, you have prosecutors, you have law enforcement, social service providers, advocates, treatment providers, and it's really a remarkable mix of people. If anyone's interested in attending, it's the second Tuesday of every month at noon, and we meet here at the Health District in room 320. So.
Right. Thank you.
Okay.
Any other questions? All right. Thank you.
Thanks.
And then I believe that concludes your report, Dr. Lutz. All right. So we're on to the legislative report. All right.
Good afternoon, everybody. All right. I'm your health policy specialist. My name's Amber Lenhart, and I'm going to talk to you a little bit, just for a brief bit of time today. I want to just introduce myself, tell you a little bit about my background, and then talk a little bit about the legislative priorities of the Board of Health and how we might come about determining what those are, and opportunities for the board to be involved in the processes that are happening internally with our staff. For a little bit of background on me, before coming back to, so I'm originally from Spokane. I actually grew up in Millwood, and it was my dream as a child to be the mayor of Millwood, so watch out. But after graduating high school, I moved away for a while and spent the 4 years before coming back to Spokane in Washington, D.C., where I worked at the Health Impact Project, which is a collaboration of the Robert Wood Johnson Foundation and the Pew Charitable Trusts. And my work there was focused on engaging communities in efforts to improve health through policymaking and looking to evidence to inform how policies, programs, plans that affect health can be made in better ways to maximize health benefits and minimize any harms. And this was done in sectors outside of health. So we're not talking about Medicaid expansion, but how does economic policy affect health? How does transportation policy affect health? Education policy? So after coming back to Spokane, I got to work at the data center with Stacy Wenzel and her team, where I supported our health promotion programs in their program planning and evaluation efforts. And I got to learn a lot about our health promotion programs and a lot of the other programs that are happening here at the agency. And then just last month, actually on September something, 16th maybe, I started as the policy specialist here. And in that time, so far I've met with our executive leadership team, the division directors, managers who work on policy issues, and some key staff like Jen who work on things related to policy. I've also been meeting with members of the Board of Health. If I haven't met with you yet, I would love to. So please watch out for an invitation for that, as well as some external folks, like people I'm meeting next week with somebody from, with other external people who work on policy issues. And what I bring to this position is a background in community engagement and equity work, knowledge of our programs here at the Health District, and then also how social determinants of health affect health and what that means in terms of all of our other agencies and programs in our community. So what about the 2020 legislative agenda? So there are some hot topics that come up pretty often in terms of foundational public health services funding. There was some great funding for foundational public health services this last round, but there's still a huge gap in what we actually need to provide the most basic services of public health. Similarly, we often focus on issues that affect our programs and our staff, and often we align this with organizations like WSALFO and the Department of Health. But I know that there's an interest in looking much more locally at what policies will benefit our local community and the needs of our community. So that's where we'll look at what more we can do to ensure that our legislative priorities are relevant to those local community needs, and especially as they relate to our strategic priorities of family violence and trauma, behavioral health conditions, and cardiovascular disease. So how are we going to do that part? Because that's the tricky one, where we aren't just doing what WSALFO says we should do. Process, my favorite P word. First, we need to understand what is the current reality that's shaping health conditions and health outcomes in our community. Once we understand that system, we can identify leverage points to address root causes of those health inequities, and then look to the evidence to see what works to improve those outcomes. What evidence-based policy solutions should we back that can improve those inequities? Now I'm going to talk you through this process. I'm going to use the remainder of my time to talk through that specific process. So in a simple world, all things could be boiled down to a direct cause and effect. It might be helpful to think of an example. So let's think about something like pertussis. Pertussis is a communicable disease, so the most direct cause is coming into contact with someone who's contagious. If I haven't been vaccinated against this disease, I might then come down with those symptoms. So vaccination might be a clear, reasonable upstream solution. In reality, we know things aren't that simple. Rather, we see cause and effect loops. Another example, I recently started exercising. Exercise impacts my heart health and increases my metabolism. This helps me maintain a healthy weight, which makes exercising easier and makes me more inclined to keep exercising. You see the loop. This example is also fictitious though. Not only that I haven't started exercising, because that was a lie, but because nothing exists in a vacuum. What about the neighborhood where I live? Does it have sidewalks? Do I have time and money to afford to go to the gym? Is my neighborhood even safe if I wanted to exercise outside? All of these things relate together to form the system that shapes the outcomes we see. And we're going to try to do this, understanding what all these systems and loops are for our strategic priorities, starting with family violence and trauma and behavioral health. And when we've identified the system, we can find bright spots or leverage points where we can make a change that will have ripple effects throughout the system and have a greater impact on health outcomes. And then we can look to the evidence to understand policy solutions. And this is where I'd really like to have Board of Health input. So let's talk about the timeline for this work. We're having a workshop on October 7th to begin making these loops. And we're doing that with some internal staff, some who have specific experience and expertise in these issues, but also some folks who are just learning this process so that we can do it on our own, because right now we're being guided by an external agent or organization. After that, we'll actually create the map. We'll take all of the loops that we create at our workshop and see how they all fit together into a big system map. And then in December is when we're going to begin to start to uncover those bright spots, those leverage points where we can take action, whether it's at our program level, working with partners in the community, or identifying those upstream policy solutions to tackle these issues. And I think that that aligns well with meetings that are happening in December with other legislators and with the Board of Health, so that you can be involved in this process and see where the board can leverage resources and where you think that our agency and our programs can be involved. So my questions that I have for you are, first, do you have any questions for me? And second, how would you like to be involved and when?
So I think, I know that there's like Party Spokane's kind of doing this whole mapping thing as well. So it's kind of, interesting to see that there's different community organizations doing it, because I think it's really important so we see what's really the whole picture. Question though is how we determine, by December kind of what our legislative priorities are, because we're starting to talk to our legislators in November.
Mm-hmm.
And so waiting till December is a little late. So I think we need to still kind of come up with some of what our legislative priorities are, knowing that this is going to be coming, but we need to, know what, what's kind of out there that we as the health district need to be aware of that's already in the legislature, that may pop up that we want to be able to, talk about or not. So I guess this is a great process, but we still need to have some concrete things
before December.
Prior to that.
Yes. Yeah, I'm really looking forward to, it was unfortunate that the policy committee meeting had to be delayed, because I was hoping to have some of these conversations with that group then, but yes, point taken, thank you.
So do you have something to contribute?
Well, I was going to say, have you done an analysis? I mean, this being the second year of a biennium, have you looked at what the priority bills were last year that did not make it through, and any indication or discussions from legislators around the state what additional public health related bills that they're looking at introducing?
Yeah, I haven't had a chance to do a lot of that yet. There were some documents that were passed on to me from the former policy specialist that did cover the course of bills that were related to the last legislative priorities and what happened to them. So I will be looking at that. And then I am, as I said, I'm going to the Washington State Public Health Association conference next week, and we'll be meeting with some folks from the larger statewide organizations to talk policy. So I hope to have a much more complete understanding of all of this by the end of next week.
So is there something, so if we tried, because we have to adopt a legislative platform at the kind of the conclusion of this before we can even start to talk to our legislators. Mm-hmm. I know we typically don't have a November meeting as Board of Health, so we're going to have, do you think it's reasonable to have something by the October 31st meeting to kind of have as a draft to look at it? I know there's only one scheduled policy committee meeting between now and then. Do you think it's reasonable the policy committee to meet more than just the once in October before the October 31st meeting? Or maybe the board's gonna have to think about a November meeting? Because I just don't, I would hate, I mean, no, I know the GSI kind of legislative meeting is gonna happen like the day after our board meeting in December. And so adopting something the day before isn't usually the greatest in our side of it either.
I'm happy to work with Anne to see if we can find time to meet with the policy committee before then, or I'm happy to also schedule one-on-one meetings with folks and see what we can pull together.
Well, let's see if we can have a draft of something for our October meeting, and depending on how that goes, we may evaluate in October to think about a November meeting of the board if we need it. And so I'll just kind of plant that seed.
Thank you.
Does that work?
Mm-hmm.
Okay.
And I just want to say welcome. We're happy to have you in the position, and knowing, we're giving you all these comments, knowing you've just, taken over that position. So thank you for taking it on.
Yeah.
Thank you.
And it's not your fault by any means. I'm not trying to say that at all. We're just trying to figure out our policy and how we're going to develop this process.
And it's a priority of mine to make sure that you have what you need. So yeah, we'll get there.
Okay.
Thanks for hanging in there with me.
Yeah. Great job. Thank you. Moving on to the financial report.
Thank you. Just have three quick little things. One, talk about the budget and the budget timeline. Ann and I looked at each other about a week ago, and we're looking at each other going, oh my God, we're way behind in the budget timeline. And then we looked at the budget timeline, and we're right on time. It feels a little pressured because we're doing a double look this year. We're bringing it in October and then bringing it for passage in December. And so years past, we've sort of had it sort of wrapped up the first part of September. And now being towards the end of September, we're right where we want to be. So the budget has, all the divisions have put their budgets together and compiled them, turned them into myself, or we can then Kim and Paula to compile the numbers. And now I'm meeting with Amelia and Ray and each division director, going over their budget, just going through what's in their budget and what they're asking for and what their known revenues are. And those meetings are pretty much happening yesterday, back-to-back-to-back meetings, tomorrow, back-to-back-to-back meetings, and Monday, back-to-back meeting. so we can get ready, because on Thursday I have a budget and finance committee meeting. So earlier when you're asking about an update from the budget and finance committee, we are going to meet on Thursday the 3rd and then again on Thursday the 10th. And the hope from those meetings is whatever suggestions come from the 3rd are going to be implemented when I bring it on the 10th, and that's going to be pushed forward to the executive committee of the board and then on to the board for the look at the end of October. The other thing that did come out of the last budget finance committee meeting, and what we were supposed to be looking at, and we did, was the fee policy. If there would have been a change to the fee policy, I would have brought the fee policy to you today for a change, but it was felt that should stay the same. So there will be a fee schedule coming to you at the October meeting as well. So we'll be hoping to pass the fee schedule and take the first look at the budget, and then move forward from there on those. But the other policy that they did want to look at was our purchasing policy. I came up at this meeting, I think a month ago, about our purchasing policies, and we were trying to implement some new purchasing policies in here. And what we discovered was we sort of started to implement them, but we haven't come to the board with the policies to get them passed. So we're going to have the formal written purchasing policies the way we'd like them to next board meeting also, so you can have input on our policies. What we're trying to do is follow the thresholds more of what the county does. And so I think we've talked about it in the past, but when we went through and looked through the actual policies, it hadn't been formalized as a change by the board. So we want to make sure we do that. The other thing another topic was, I want to thank Councilmember Thompson, because she actually sent in some questions this month. And I know you are on the vouchers, and I know you already passed the vouchers, but I would like to give her the answers on a couple of these, because a couple of them have come from other board members as well. So one of the questions came about the CNC containers. And what the CNC containers are is they're little bottles with locking sealed lids that the methadone program uses when they let eligible clients take home week or 2 week carries. And so we have to buy these bottles regularly. You'll see them come through about once a quarter, X amount of thousands of these bottles coming through that we take out, and then they have to follow a certain protocol in order to be able to take them home for the week or 2 week, rather than having to come here daily to get dosed. The other one that was asked about was a company called Rev.com, and that is a company that does transcription work. So we've been using them a lot when we have focus groups. They tape the focus groups by video, and then this company transcribes what was discussed at the focus group. They also have been used for interpretation, and in some cases where they do some interpret work for us also. So the last thing I need to talk to you about is our auditors. We had our audit exit at just this last week. I want to thank Commissioner Cooney for coming to the audit exit. That was much appreciated. And as you know, when the auditors come here, they have to look at a certain amount of the federal dollars. This year they had to look at 20% of our federal dollars. Just by using the WIC program alone, that covered that 20%. So they, as accountability, they went through the WIC program and pulled how things were being done there. No problems came through that at all. It was all very nice. The other thing they come do is they come look at our reporting requirements as far as GASB's 45s and 68s and 75s and all these reporting things you have to do from an accounting standpoint. And as you may remember, but I'll let you know, is the levels they give you as they leave are either exit items, and there's a couple exit items that they inform you of. There's a management letter, which means that we'd like you to correct this or it could turn into a finding. And then there's a finding. And so unfortunately, this year we actually got a management letter and we got a finding. So, and what they're more on the reporting of the numbers. And so we crunched trying to get the annual report done by that May 30th deadline. We're still working on it at 7 o'clock at night. Submitted it to the state because it's due that day. And then the next day, our auditor in charge said, hey, it's missing some numbers here. And although they were on the working papers that were being used, they didn't get put into the submitted papers. And they have a new rule now, whatever you submit is it. They don't come back and say, oh, you want to correct that and get it over with. And so from that, we got the finding by just not having that amount of dollars on there. It was corrected the next day. All through the audit, it was corrected. The version that's out there now is corrected. They still find a finding. The management letter thing was a little stranger because this is our LGA money that we get from the state. We get it every year, and the state treasurer just sends it to us. Well, the auditor chose that money as one of the ones to look at this year. And although we've been getting it the same way for 20 years, we've always just put it in the current year we get it. January 31st, we get the payment. July 31st, we get the payment. And they came back and told us that January 31st should be an accounts receivable from 60 days prior because the legislature releases the money 60 days prior. We just don't get it till January 31st. And so they told us that that is a management letter thing. They first tried to jam it together as a bigger addition onto the finding. We argued it down to a management letter. And but we have those two things. So the management letter we have to give a response to, which we did. And then the finding, we have to do a corrective action plan, which we have. And so Ann's going to be sending out these final reports with the corrective action items that we've done on there. And just want to make sure the board was informed that happened. What it means to us is now instead of 20% of the federal dollars being looked at next year, it jumps up to 40%. So that could be WIC in another program, or that could be 5 programs that go over that 40%. And then we have to not get a finding for 2 years to go back down to low risk. They don't say we're high risk. They don't use high risk anymore. They go, there's low risk and you're not low risk. So we're not low risk. So, any questions? They were Spokane.
So I'll just follow up on that because I was at the Exit conference and as a former state auditor, I can say I was annoyed that on a clerical error for accounting that they're going to write a finding that then is going to affect your single audit. I find annoying, and so I'll be making that comment to the local government committee that for the state that monitors and talks with the auditor's office because it was just a clerical mistake of that. I think it was in the cash flow statement. That there was a couple of numbers that were 0 instead of having the numbers in it. And so once those numbers were in it, it all, made sense. And Kim had all the support for that. You guys did everything you needed to do. So it just was kind of as she uploaded, the upload didn't carry those numbers in. So it wasn't even that you're trying to not have them in there. It's just it's a process. And so I find it, I'll say for the record, annoying that that they chose to do a finding on that that then affects us on the single audit side, especially when there was no intention or any of that. And so if that's their new policy, that I will be talking to the state auditor about that. Because, usually findings are for things that you really need to correct and change that are big issues. The dollar amount of this was significant, but again, it was a clerical mistake that, got corrected and the financial statements are, correct. And all the accounting that led into that, is correct. So, so I just want to say thank you guys for doing the job. You're doing a good job. Yeah. Don't let this finding have any effect that way because it truly is, it was a clerical error in just the upload of how it all happened. And so And I know you have procedures in place so it doesn't happen again in the
Yes, very
future,
much so.
you know, which is great. But like I said, I find it, you know, disturbing that they would have that then affect us on the single audit side. And so the other thing is that, you know, this year with the health district, sometimes it happens differently, but the accountability audit was done at the same time as the financial audit along with the single audit. And so those were the only things that they could come up with. So you did a good job.
Oh, thank you. Kim does a great job. So thank you. Any other questions on financial? Thank you.
Now we're up to our public health and homelessness report. Mr. Letts, do you want to do the introduction?
So obviously homelessness is a hot issue in our community, and given that we've been talking about this for a number of months, I felt it would really be important for us to talk to the board about what we're doing about homelessness, both, and I would say primarily indirectly, but certainly directly in some capacity. But then also, I want you to sort of be able to hear from people who are actually doing the work directly. And so, you know, it's estimated right now when I looked at some data that there's probably 50,000 individuals who are living at or below the federal poverty line throughout Spokane. And so many of these individuals are living homeless. And to some degree, you know, what we deal with oftentimes is intergenerational. Poverty begets poverty. And the challenges that people living in homelessness and or people who are living at that level have and they struggle with oftentimes begets another generation that begets another generation. So what we have been doing locally, I should say within the agency itself, is we touch upon homelessness in a lot of different ways. So a lot of our client services, be it working with individuals in the opioid treatment program, in the syringe service program directly, you know, we're interacting with those individuals on a daily basis, trying to address their multiple needs. We also do it indirectly through programs like WIC and the Nurse Family Partnership, where again, that one-on-one relationship with which our staff build with the individuals is really essential to developing the relationships, the trusting relationships that then allow them to reach out and look for other levels of assistance. One of the areas you've heard about is Priority Spokane. Priority Spokane has asked the data center to do an evaluation of its work around homelessness. And just to give you some numbers that are somewhat preliminary but will be coming out soon, they looked at a program that partnered with Catholic Charities, and Lindia can correct me if I get anything incorrect here. But the data center, in looking at the success of this Catholic Charities program, looked at specifically working with families in 3 areas. They were in the Deer Park K-8 grade schools, Logan Elementary and Stevens Elementary, and looking at caseworkers in those schools. And what they identified was that there were about 304 families who were living either in a homeless situation or in unstable housing. And those individuals, those families were referred to these caseworkers, almost 50% engaged fully with the caseworker. And of that 50%, about 3/4 actually found themselves either housed or stabilized after that program. So again, I think real kudos to Catholic Charities, but also to the work that the data center has done to evaluate the program, because again, data are important and we need to know whether or not programs actually work or if they don't. So with that as a segue, what I'd like to be able to do is to just introduce our speakers today. Ashley Beck, who is our senior lead research scientist in our data center. I'm going to ask her to sort of present the data. And Ashley's background is in prevention science. And I think that's really important because, again, we can treat homelessness as an outcome, but ultimately we need to be looking upstream to try to prevent it from occurring. And that's, again, where I think the strength that Ashley brings to the work that she does for the agency. I've asked colleagues from the Continuum of Care Board, where I serve, Edie and Angela, to speak about their work. They work for transitions. And again, I want them to be able to provide for you sort of that on-the-ground experience. And then finally, Amber is going to come back up, and she's going to talk about policy opportunities that the board can be looking at, but also more broadly what the community can be looking at to address the issue. So, Ashley?
All right. I'm Ashley Beck. I've met several of you, I think, in different contexts, probably presenting data. But as Dr. Lutz said, I'm the senior research scientist here in our data center. I've worked quite a bit on homelessness over the last 5 years. I've been with the data center for 5 years. And I've worked on it through working with Priority Spokane on their program evaluation and on some kind of deep dive assessments into homelessness in the past. So I'm going to give a pretty high level overview of some of this data. And I want to say now, please take this a little informally, even though I have a microphone and all the whole thing. And please stop and ask questions if you stop me if you have any questions. It's complex data, and I want to make sure that it's helping to paint a picture of how complex the issue is in kind of a straightforward way. So stop me if you have any questions. First, homelessness. I want to make sure that we're all on the same page in terms of homelessness being a public health issue. So homelessness is rooted in health causes and social determinants and poverty and trauma and issues that are of high importance to public health broadly. So that's the experience that we're coming from. It also relates to homeless individuals experience disproportionate levels of severe health outcomes. So from this prevention standpoint, looking at the needs of homeless individuals is preventative and helping to address some of and prevent some of their severe health-related outcomes. So addressing and preventing homelessness is critical to public health. Okay, so first I want to start with defining homelessness. Homelessness, again, is a complex issue, and in order to better understand the experiences of homelessness in Spokane County and how we measure it, we first need to define it. So first, the most commonly used definition of homelessness is considered sometimes called literally homeless. It refers to those living in a place not meant for habitation, a safe haven, emergency shelter. On those unsheltered or sheltered, homelessness is kind of that wider term. This is the definition used by HUD and housing service providers. Most housing service providers is this literally homeless definition. Then we have chronically homeless. So the difference between chronically homeless and homeless is that chronically homeless individuals are people who have experienced homelessness for at least a year or repeatedly over time, and struggle with a disabling condition such as severe mental illness, substance use, or a physical disability. So that is what we're talking about when we're referring to chronically homeless individuals. Next, we have unsheltered homelessness. So to make things even more complicated within these complicated definitions, we have sheltered and unsheltered homeless individuals. Unsheltered homeless individuals are those who have been kind of identified as spending the night out of doors. So specifically through the point in time count, we're able to see how many people are not sheltered during the night. Then we have, kind of widening our definition, we have unstably housed or at risk for homelessness. This is a little bit of a complicated definition, but it's very important to understand that this unstably housed as a unique kind of definition of homelessness, because some federal agencies and other organizations use the combination of literally homeless and unstably housed to represent homelessness. Unstably housed refers to those who are doubled up, couch surfing, or are in situations, maybe in this situation, they're not a week away from being evicted, but maybe a month away, or they've had several warnings for eviction, or they are late on their mortgage to a certain point where maybe they don't meet that 1 week criteria, but they are at high risk for becoming literally homeless. So these are important distinctions. I'll get into, next I'm going to get into how these definitions are used and how these definitions allow us to track homelessness. So to, again, paint the picture and really understand the issue of homelessness in Spokane County, we rely on our tracking and our information that we have available. So we have how homeless is measured. We have the it's called Everybody Counts, the current point in time count information. That is an important perspective of homelessness because it is consistently used federally, and that allows us to kind of compare different areas, but also really brings us consistency in how we monitor this highly complex issue. Another source of information is the Office of the Superintendent for Public Instruction. This perspective gives us information from all of the schools. They collect all of the schools in Washington State, and what they do is if a student is identified as homeless during the course of that year, a flag goes up. So when that flag goes up, we have information about how many flags have gone up in Spokane County this year, or over the course of the year. I'll show that. We also have the Quality of Life Survey, and some recent additions to the Quality of Life Survey have unstable housing for the adult population. So this provides us with, again, it will never be the complete picture of homelessness, but it's a comprehensive picture of homelessness when you add these things together and really kind of triangulate to better understand that. So I'll dive into that a little bit more. So each of these sources has their limitations. But they provide that robust picture. So some of the limitations with each of these: one, the transient nature of the homeless population. You cannot count people who don't want to be found or counted, or you can't count children who have not had indications come up through the school that they may be homeless. So again, there will always be a degree of this underreporting in this. So I'm going to share some numbers that help to paint this picture, and again, understand that if anything, this is an underrepresentation of the full scope of this issue in Spokane County. Are there any questions about these sources before I move on to the numbers? No? Okay. All right. Okay, a lot of numbers here. I'm going to walk through each of them. So using these data sources, we can really begin to understand how much homelessness exists in Spokane County. First, there are 84 unsheltered, chronically homeless individuals. 84. This group is who are often referred to and are often the topic of conversation in terms of intervention. When you widen that scope, you have 231 chronically homeless individuals. So again, the chronically homeless are those who have been homeless for a year or had repeat instances of homelessness, along with a disabling condition. Then you have 315 unsheltered homeless individuals. So widening this scope, you have 1,070 homeless households. Within these households, we have 1,309 homeless individuals. Now switching to the different kind of perspective, our OSPI data shows us that we have 2,840 homeless students who have been identified in Spokane County. Our Quality of Life Survey allows us to see that we have 14,901 unstably housed adults in Spokane County. Widening that even further, we have 54,506 adults stressed about their cost of housing. So when we take a look back at each of these things, these adults stressed about their cost of housing and not being able to afford the cost of their basic needs, this is our widest picture of the risk for homelessness. How much poverty we have in Spokane County really is the focus of, it needs to be the focus of our prevention efforts. And when you consider the populations and each of these as a unique population, different interventions will be needed, which is what Amber will touch on. And this really allows us to get past not be so focused on just any one of these homeless populations, but also to consider how each of them in their own unique needs. Any questions about this data? Yes?
Just a quick question on the term stress.
Mm-hmm.
Is that term hard? Do you actually have metrics that are applied to stress?
This is a self-report of stress about finance. So it's one thing that we've recently added in terms of to the quality of life so that we can start to get a better picture of that instability. So when you think about the things that make the impacts that poverty and cost of housing and things like that might be having, this is this is our kind of first indicator of that issue.
So that indicates adults that are living paycheck to paycheck who are not able to, their income may not justify or be able to supply housing.
That indicates, that's exactly what that indicates. And the important thing there is that this is not individuals who are making a certain wage. This is not individuals who are, you meet traditional definitions of poverty, but these are individuals who might be in situations, even let's say a middle income household, where their cost of housing and their cost of living is so much that it's causing financial stress that they may not be able to meet their basic cost of needs. So an individual can go from having a relatively high income or living in a fairly expensive dwelling and quickly find themselves unable to meet the costs of their needs and become doubled up or at risk for homelessness or become literally homeless. You can go from each of these levels, no matter kind of where you're at, and find yourself in that situation. So I think that is one of the important, again, these are all very different indicators of the issue, and that's its own kind of unique category. Thank you. Any other questions? No? Okay. So now I'm going to, this is where it might get, there's a little bit more data, but I'm going to go into some of these specific populations and just shed a little bit more light on what some of these other, these definitions of homelessness look like in Spokane County. So first, since they're the most visible and often the most talked about in terms of our issues, I want to focus on the unsheltered individuals. So unsheltered individuals, again, there were 315 unsheltered individuals in 2019. You can see that in this graphic where some of the unsheltered individuals were found. And again, I want to kind of reinforce that previous number of that 84 of these were chronically homeless and 231 were not chronically homeless. So 231 might have been a first instance of homelessness or not. Again, they're uniquely different kind of populations within this unsheltered. And this just gives you a little bit of picture of who's included and how robust our point in time count is, and that it captures all of those areas. So continuing in unsheltered individuals, this shows us the unsheltered, the top line is unsheltered adults, this middle line right here is unsheltered families, and the yellow line are unsheltered children. So what I see when I look at this graph is really that the levels of unsheltered families and children have remained pretty low and stable, and compared to unsheltered adults, which we've seen a pretty dramatic spike in over the last few years. Again, this is the unsheltered, maybe chronically, maybe not, but this is just unsheltered. And what I think of here is what's the story behind this graph? And some of those factors might include things like the rising cost of housing or changes in housing services. So if there are changes to services that are provided, we will see changes in whether individuals or families are sheltered or not, or which kind of, where they find themselves sheltered versus emergency or transitional housing, things like that. Okay. Yes?
What, and if you maybe know what the year was, wasn't around 2017, 2018, they shifted to a mobile-based app on phone to
the counting?
Have more reliable data. So could it be also that it's just got better at actually finding the individuals and getting the data?
All of that could be partially true. If that were all of, I'm not sure. I wish my colleague David Lewis was here to talk about the point in time count part, because he's so great at knowing exactly what happened each year. But one of the things is we don't see the same spike with homelessness. So that overall count of homelessness did not spike in the same way as this unsheltered individual would. So I think if you have more people, or if where they are has changed, those things definitely could have an impact. I would question if it was to that degree. So I would love, that would be a great question I could follow up on with David and his perspective if you're interested in it. Okay. Any other questions? Okay. So this is chronic homelessness, and this shows us, see, this is a spike at a, kind of that different point, or actually a dip in homelessness. Again, this is the 1 year homeless or reoccurring instances of homeless. I want to follow up with only 84 of these were unsheltered out of the 231. So that's 147 chronically homeless that were sheltered as well. So each of these different points that I'm going to show you really just reflect a little bit of the picture of some of the unique needs and the unique characteristics of each of these populations. So chronically homeless individuals might require different services than homeless families or unsheltered chronically homeless individuals. So that unsheltered within that might have a different set of needs. Okay. All right, so this is that homelessness overall where we did see a little uptick in that 17, but really over time, so if you look at this row right here, we've had peaks and valleys, but not a lot of substantial. There was a dip in 2016 and a rise again through pretty consistently rising since 2016. So, but again, it has varied previously too. So this is just important to know of where are we now. And that's really the great thing behind the point in time count is that it gives us kind of that the best census that we can have of the issue at each given year. Okay, so this also shows, again, those chronically homeless and then those homeless families with children, of which there were 97 in 2019. I'm going to dive into homeless families a little bit. This shows some of the top line here is those who are in transitional housing, which has really consistently declined over time, that transitional housing, which is probably a reflection in some of the policy changes over that time as well. We see pretty stable levels, fairly stable levels of emergency shelter usage of families. Then we have those unsheltered families, which have also stayed fairly stable, relatively stable. Okay. Any questions about homeless families? Okay, this information here is homelessness and the experience of those who were identified as homeless and their prevalence of having different issues like severe mental illness, chronic substance use, living with HIV and AIDS, and survivors of domestic violence. So these are percentages actually of the entire homeless population of how many have those. So I want to ask you all, what jumps out at you when you see this graph? Or these percentages, the 24.3% of all homeless individuals that experience severe mental illness, the 12.1% with chronic substance abuse, the 9.5% survivors of domestic violence, and the 0.6% living with HIV and AIDS. Anything surprising about this information? What do the rest of the people have? That's a great question because there are a lot of factors that homeless individuals experience and likely several of these factors as well. So this is just one small picture of that, and I'll touch on some of the other risk factors that we may or may not have information on. But
I'd say the thing that jumps out at me is that if you talk to law enforcement, if you look at the county jail, domestic violence reports are really through the roof right now. But if you looked at this graph, you would think that it's actually on a decline. If you look at the survivors of domestic violence, the peak was in 2014 at 238. We've actually seen a steady decline, which kind of goes against what we're seeing in the rest of
that's an interesting observation because I think that what I would say with kind of that is that when I see this decline, I see, oh, we started having more effective housing services available for survivors of domestic violence. So it's unlikely that domestic violence has gone down in that point. But when we stop seeing people being homeless, we start seeing that something did its job. It kept them from being homeless. So we really consistently see that when in some of the things that I saw with children and families, there are far fewer and far more stable levels of families and children because we frequently hear that housing services are easier and to come by for families and children than individuals. So when I see that stability, I see that the services have remained pretty consistent. And I'd love to hear if you have a thought on that piece.
Because you're placing the domestic violence measure within the whole. You're placing the entirety of the domestic violence situation within all of the homeless population, not just the possible victims, which tend to be primarily women. So I think it probably skews it a little bit by that. I'll also say, just in terms of services, actually our services have lessened over the last few years. About 4 years ago, HUD stopped paying for transitional housing. So the federal government stopped paying for that. That's a best practice for survivors of domestic violence. And so the YW and ourselves and Lutheran have worked real hard to find other sources of dollars. But actually the services are less than they were about 4 years ago.
Thank you. Thank you. Which is why it's so important that we have partners who work in this when we're trying to interpret that data. So I really appreciate that. Okay. So a couple of, I'm going to kind of, I don't have very much time, so I'm going to kind of wrap up some of my different things. This just is a quick little reflection of what people self-report as being their reason for homelessness. One, lack of income, and if you combine kind of evicted with lack of affordable housing, you have housing. So housing, poverty. You also have family conflict and some other items on here as well as being, again, that even within all of these circumstances, that clarity of saying that these were the things, this is the reason that I am homeless. So this was a self-report. So when we get into one of my favorite things to talk about as a prevention scientist is risk and protective factors. And the causes of homelessness are so complex and interrelated that if you can break apart these factors, you can get to kind of prevention. And again, we have unique things here would be trauma, racism, debilitating illness, each of these different things. Again, these are common risk and protective factors. We hear the same conversation and the same risk factors that lead to substance use, that lead to each of these other suicide prevention, all of these things. And really, homelessness is one of those most severe outcomes that you can have of how these things all weigh out. But again, within the research and all of the literature, poverty and lack of affordable housing is consistently what the field is saying are ultimately the root causes of homelessness. So why that's important, poverty and affordable housing are the things that Amber will talk about as kind of being addressed, but really understanding that population and the other factors that they're experiencing, this information is critical. I want to leave you with, hopefully this is not new information. This is a super common psychological theory. This is Maslow. It was developed in 1943. It's referred to as his proposed hierarchy of needs. So I want to just say from the research and from the field that it's critical that individuals have their basic needs met before they can have things like their psychological and growth and self-fulfillment needs met. This is so important when you're considering homelessness and different strategies, and that you really remember those physiological and biological needs for food, shelter, sleep, warmth. Without that, and without having that covered, you cannot meet those other needs. So when you're talking about interventions, this is a super critical theory to remember. Hi, I'm Edie Rice-Sauer. I'm Executive Director at Transitions, and this is Angela Chapman. She's going to be my buddy today. I'm going to share a number of things that will be repetitive, a little bit duplicative, and I think what I know about preaching is you're supposed to hear things 3 times before you get it, so maybe that's a good thing. I'm going to talk about causes, similar to what we just heard. I'm going to talk a little bit about barriers to housing, and then I'll share with you a little bit about Transitions. You're getting a brochure, but about what we do in the community. So I'm going to talk about domestic violence. We keep hearing that today, and that's, for us, what we see in terms of the data is the number one, well, you saw the second reason people are homeless is family conflict. That generally is domestic violence. 90% of the women we serve in residential settings come from a domestic violence situation, so they're survivors of domestic violence.
And as we just heard, we were hearing a lot about the point-in-time count, and often that gets sort of demonized as it's a one day a year, and how can you really trust it? And even us as providers say the same thing, that it's frustrating, but it has been going on for many years. I think it's probably, I don't even know, 15, 20 years now we've been doing the point-in-time count. And so it's a day in January, and so it's, at least over time, it's a really good data piece to review. What we saw, so 90% of our residents are domestic violence survivors, but in 2018, the point-in-time count saw a 24% increase in those identifying as fleeing domestic violence. So that's a huge number. As I mentioned, we have actually lost services over the last few years. The YW did not get renewed for a grant for transitional housing. We did get an Office of Violence Against Women grant about 2 years ago with Lutheran and the YW to provide some of those transitional housing units and to bring them back on into the system. But it's nothing like what we really need. And I wanted to share with you, for one 6-month period in 2017, through this Office on Violence Against Women grant, which is a Department of Justice grant, we serve 6 families. So we have 2 units at one of our sites and 2 units at another site. And so we were able to serve 6 families, but we turned away 34 in that 6-month period. So we were unable to provide them with housing. So another cause of people being homeless, especially women, I'm going to focus mostly on women, is poverty issues. I like to think of poverty as lack of opportunity, and lack of opportunity in lots of different areas. So it might be lack of opportunity in education or lack of opportunity in healthcare. What I see a lot with the people that we serve, a lot of women begin, maybe they go to the community college and then they become pregnant and then they stop going back to school, and then they end up often with a major bill that they can't pay. And so then fast forward about 15 years and we might run into them. They've decided they want to go back to school, but they can't because they have this huge debt that they have to pay back before they go back to school. We and some other agencies have scholarship funds that are available to provide for them so that they can pay at least $1,000 on that bill. But that's often a big barrier to someone going back to school. They might also have become drug involved as a young person. Fast forward again a few more years and they realize that they really want to go back to school or try to find another opportunity for themselves. And that's just a challenge, as now they're 30 years old and going back to school is difficult. But education is really important for many of the people we serve, and getting back to school is just very hard. Also, healthcare opportunities that for healthcare are often not available to them. Dental especially is difficult, but ongoing healthcare for many of the people we serve is very challenging for them to find. And just as a data piece in Spokane County, 75% of the heads of households of families who live in poverty are women. So that's a huge percentage of the people who live in poverty. I want to talk a little bit about barriers to housing, and we've heard a little bit about this, and so we'll talk some more. One is the incredibly low vacancy rate in Spokane, and I shouldn't even say Spokane, it's across the country, but let's talk about Spokane County. I heard yesterday that the vacancy rate in Spokane was 0.8%. I thought it was about 1.4, which is terrible also, but it's 0.8%. So you can see how it's, especially as a private landlord, you have lots of options about who you're going to be renting to. And if somebody comes with a voucher, we know that often is a sort of a red flag for some people. I don't want to rent to them. Even though the last legislative session, we saw some huge work on trying to eliminate that barrier, it still is very much there. And I think we see it all the time in the people we work with. We know in Spokane County, for every 100 families who are looking for housing, affordable housing, there are 12 units available. So it's very challenging. And in 2019, the National Low Income Housing Coalition said that you needed $17.50 in Spokane to afford a 2-bedroom apartment. So if you know minimum wage is $12 or $12.50, we're nowhere close to that. What we see in our programs are often very significant health issues, and I thought especially you would be interested in these issues related to heart, feet issues, a lot of different issues because they're walking in wet socks, wet shoes, in the snow, diabetes issues, UTI and incontinence kinds of issues, often weight issues that are really debilitating for many of the people we serve. Another piece that gets in the way of somebody getting into housing is their criminal history. We often experience many women who have actually participated in a crime with their male partner. Now they've served some time and now it's really difficult for them to get housing because of that. And then lastly, I just want to mention many of the people we serve have little or no employment history, which is one reason why we do a program called New Leaf Bakery Cafe. We realized many years ago that many people wanted some kind of income, but they really had no idea how to get that. And so just the basic employment recommendations and requirements was something that they didn't know. How to not text on the job, how to show up on time, what to wear properly, those sorts of things. And so that's, especially as public assistance wanes, that program was really started to respond to that, but we just see many people who have no experience with being employed. And so part of our job is to provide them also with opportunities for volunteer experiences early on, so they at least get to, maybe they answer the phone at the Women's Hearth, or they work in the storage closet, or those kinds of things, and those can then go on a resume. The other piece that gets in the way of people finding housing is not just the fact that they don't have an income, but even if they do have an income, childcare costs and the whole availability of childcare. I'll have to say we're working with the data center here to complete, very soon we'll have an after-hours childcare. Well, it's not really an after-hours childcare report anymore, it's just childcare in general in Spokane County. Your staff have been amazing, but to look at how many people really choose to use their family and friends because they just can't possibly afford to find quality, accessible, affordable childcare, and the kinds of ramifications of that. I wanted to mention about our program. So Transitions is a local not-for-profit. It was actually started as Transitions in 1995, but it really began as 3 small agencies before that. So in 1986, Miriam's House was started on the Lower South Hill. That's a lovely home. It used to be a convent, so all the rooms are tiny. You know, they say that a convent closet only has to have room for 5 habits, is what I hear. So those rooms are small. We can serve 9 women there. They are referred to us through coordinated assessment, which is a program that coordinates across the community people who need services, and they're routed to us or other agencies. So Miriam's House is for women who are single and homeless. Transitional Living Center, or we call it TLC, is also for women who have been homeless, but they also have children. And we have an adjacent child care center, a licensed child care center there. Thus my interest in the importance of child care and how to maintain that. The Women's Hearth is down on 2nd Avenue. That's a drop-in center for women. And women who are homeless, we see about 60% during the week who are actively homeless. We're now open on the weekends, and we're seeing 70 to 80% of the women who come in are actively homeless. Also women who live in subsidized housing who may have used us previously when they were homeless, but they are finding support there and want to continue to come there. And then I always say women just like me who maybe got stabilized, they're in their own home and they still find it a really important place for them to find community. New Leaf Bakery, as I mentioned. And then we just recently opened our cottages, the Homeyard Cottages. Those are 24 small cottages. They're 1,000 square feet or smaller on 2 acres with a community building, and 15 of those are ultra efficient. But those are permanent units, so somebody can stay there as long as they follow a lease. If you ever want a tour of those, let me know. I'd be happy to show you, but they're pretty exciting because we have been working on that for a long time. I'm honored to ask Angela to come talk to you. Recognize that she's sharing parts of her story that she's most comfortable sharing, and so I'm going to stay up here with her.
Okay, well, thank you for listening. In November 3rd, 2012, I became homeless. We lost our house to foreclosure, and it took about 5 months before we were even accepted into transitional housing because I had a 15-year-old son who couldn't stay at UGM, wasn't accepted into most of the shelters. So during that time we were house to house, and I don't know if I was considered homeless because at the time I don't know what the definition was, if you were doubled up or however that works. But once we were accepted into transitions, they made an exception for us, for my 15-year-old boy to stay there.
Which
And
scared us all to death.
yeah, but it turned out to be the best thing that ever happened to me. It actually just changed my life in so many ways that I actually work there now. Now I'm executive assistant there. But the point is, if these programs work, you know, I went from literally being on the street, house to house, to permanent housing, and now, you know, we have our own place, and it's just all worked out in wondrous ways. So if you want to find out more about transitions, you know, come meet some of the residents, come check out our facilities and see what it's all about. Okay.
Thank you.
Yeah.
Do you have any questions? Bob, do you have any questions? Okay. Okay.
How many of the homeless are employable but unemployed?
You know, I often hear the anecdotal description that about a third are employable, a third could do some kind of like peer support employment, and then a third are not employable at all. That's kind of the way we tend to look at it. You know, but a lot of people just have no experience. So what we find at New Leaf is we do some very basic skill set pieces with them. A lot of conflict resolution. Like a lot of people think that if you get in a fight with your boss or a conflict, you need to leave your job. and so that's kind of a mindset I think a lot of people have, or a conflict with your team workers. New Leaf, we have a kitchen and there are about 5 trainees at a time. And so they learn how to work together and also do safety kinds of pieces. But I think that's some really basic skill sets. There's a number of programs. Goodwill has great programs. UGM has a training program as well. We would like to expand. We're actually hoping to, our plan is to move into the public library when it opens in 2021. But we have a cafe so people can get job training program on the ground, like a front of the house training. But yeah, I think some really basic skill sets are what everybody needs to get going. But you know, then the consequence of that often is at this point, the salary they get, their hourly rate is very low. So as I said about this 2-bedroom apartment, you got to make $1,750 to be able to afford that, and you're probably making $1,250. Anything else? Thank you so much.
Yeah, thank you, Edie. All right, that brings us down to board member check-in. Oh, sorry.
Sorry, I'll be quick. Thanks so much to my the people who spoke before me. That was amazing. I am going to talk very quickly about policies that address homelessness. And when we first think about policies to address homelessness, I think we often think about those unsheltered, visible, chronically homeless individuals. And some common approaches that we see are things like sit and lie laws, you know, that criminalize lying on the street, on the sidewalk, or even sitting on the sidewalk. Panhandling laws that prohibit aggressive panhandling, or even in some communities, panhandling is completely illegal. There are policies that might limit food distribution in certain urban areas to try to prohibit or keep groups of homeless people from forming. There are sweeps that happen, you know, where they come in and clear out homeless camps and remove all of the belongings that have accumulated there. Selective enforcement of specific laws that are fairly neutral, like jaywalking, that are selectively enforced around within homeless populations. And then hygiene ordinances related to public activities and hygiene, like public urination. These are things that we I think typically come to mind, and these are all things that I think address that really visible part of homelessness that maybe makes people uncomfortable. But what the science says is that these policies are ineffective. They don't address the root causes of homelessness. And we heard from Ashley and Edie and Angela that really it's poverty and a lack of affordable housing that are at the heart of this issue. And so some evidence-based solutions do exist for addressing these issues. And first and foremost, it's housing. Get people into housing without requirement. According to the Urban Institute, policies aimed at ending and preventing homelessness should prioritize the use of housing first model, given its positive housing, health, and economic outcomes. And housing first means getting people into housing, whether it's transitional housing or permanent housing, without requiring them to make any commitment to sobriety or treatment, but just getting them into housing. A review of 31 studies showed that housing first resulted in faster housing placements, increased housing retention, including among individuals with co-occurring substance dependence and mental disorders, decreased shelter use and fewer jail stays, and a higher perceived quality of life and sense of choice for individuals who experienced homelessness. Housing subsidies and vouchers can also be useful at getting people into housing. By spending less on rent, families can also be better able to meet food and other basic needs like transportation, educational support for children, and healthcare. And then permanent supportive housing. For those individuals especially with serious mental illness and disabling conditions, permanent supportive housing provides other services, whether it's case management, substance abuse or mental health counseling, assistance in increasing income. We heard about the job programs, training in independent living skills, and other supportive things for tenants to keep you in your house. Poverty, we heard, was another driver. So any policies that promote stable incomes. So whether that's employment access, job programs, or helping people access benefits that they might be eligible for, like their disability benefits or Social Security, so that folks can have that income and afford to stay in their homes. Improved data collection. Also, we heard about some of the limitations. We are doing, I think, our best to collect the right data on homeless individuals, but we can't really understand the depth of the problem and the comprehensive nature of homelessness if we don't do a really good job of collecting our data. There are a lot of gaps, especially around how data is collected for homeless youth, and that I think is the data says, or the science says, is an area that benefits from improved data collection. And lastly, prevention. And specifically prevention that is effective and efficient. So we can keep people in housing using permanent deep rental housing subsidies and eviction prevention programs to keep people in their homes. And then screening and services for high-risk individuals such as psychiatric patients at discharge, people who've been formerly incarcerated as they're re-entering into society, foster youth, veterans, and others. So we can identify those potentially unstably housed or people who are at risk of homelessness and make sure that they have the services that they need before they become homeless. There are some great resources out there on evidence-based strategies to address all kinds of issues. So I just want to highlight one very quickly. This is the Results First Clearinghouse. It's Pew MacArthur Results First program based at Pew in Washington, D.C. And I just did a search after I worked on this. I did a search for homelessness, and you can find evidence-based policies and other sorts of solutions and see the evidence behind them here in this clearinghouse. It's a pretty cool resource. And I just want to leave you with this quote from the United States Interagency Council on Homelessness, emphasizing the point that policy solutions truly should address the root causes of homelessness. The criminalization of homelessness creates a costly revolving door that circulates individuals experiencing homelessness from the street to the criminal justice system and back. Any questions for me? I know it's about time.
I have a question. Why wouldn't you require sobriety, for instance? Because anybody can do that.
Well, we actually have a Housing First expert in the room, Amelia. I don't know if you can speak to that. Right, there's no requirement of sobriety.
Right,
So the question was why.
I'm just asking why you wouldn't require something, well, that in particular, because anyone can get sober.
I think that with Housing First, the idea is to put the wraparound services and case management with the individuals so that if they are interested in seeking sobriety or recovery, that those services are available, but that it's not a barrier to becoming housed. So you can come in, but they will work with you on that path to recovery. It's just not seen as a barrier that if you are someone who has a substance use disorder or are actively using, they don't just immediately stop you from participating in the program.
And yeah, and some of those
I also don't require you to go into a program.
Housing First does not. It's encouraged, but it's not required.
If your ultimate goal is reducing homelessness, literal homelessness, then having people in housing is the outcome, I think, that's ideal. And so these, as Amelia said, these policies or these Housing First models just get people into housing, and then let's address your issues. I know Catholic Charities put out an interesting document that describes some of their programs, and I know that they have some housing where folks can live there and they can deny services as long as they can continue to live there and not be a disruption to the community. And then if something happens where that person causes a disruption, they are required to participate in those services.
How come on the point in time count, the drug use and alcohol use for the main cause of homeless are separated into two categories? Because if you add them together, it's actually the number one, just substance abuse in general, or addiction, general addiction, whether it is alcohol or drugs, would be the number one cause if those were combined.
Ashley?
Great comment and kind of reflection on that. So I'll kind of reassess again.
You gotta talk in the mic.
Oh, sorry. Yeah. My first meeting. Okay, that's a great comment. I do not know why that was presented in that way. And yes, you can kind of, what you can do with each of those. The nice thing about the specificity is that you can break it down, but the other thing that you can do is combine them. So I'll look at that and how we present that, and we could consider putting that into just substance use. And again, that was a self-reported piece of that too. So that is one of the top pieces.
And I apologize for that category. Was that the main cause? I mean, were individuals able to select multiple answers for that question, or was it stated as what is the leading cause? Or
I do not have that in front of me,
Okay.
and I believe that you can select multiple reasons for homelessness. Mhm.
Okay, I wasn't sure because I mean the numbers are very low. I would think if it was 74 being the top and the one. I don't know what the size of the field was that answered that question.
I'm going to
on
double
whether
check
it
that
was-
and get you, if you're interested in getting some follow-up
I
information.
absolutely am.
Because I think it would-
If it was asked in a way, what is the number one cause, or what is the reason? I think it's very reasonable to assume that someone that answers lack of income could also have a substance abuse issue as well, or
drug or
family
alcohol.
conflict could have drug or alcohol as well. Or so, I think so. Yeah, I would like to know if folks were able to answer just one or multiple on that.
And all the point in time, the way the surveys are done, that's dictated by the federal government, so everybody does it the same across the country. So all those categories, we didn't add those or change them. It's set by them.
But I think, Ashley, you made a good point about how you can aggregate and disaggregate this data in interesting ways. If you add together the housing-related issues, lack of affordable housing and evicted, then that rises to the top. If you look at family conflict, fleeing domestic violence, and family rejection, that's a big driver. So you can kind of add them up however you want. May I sit down, or do you have any more questions for me?
Seeing none, thank you. Right now, I think we're on to board member check-in. All right. Start with you, Kevin. Nothing? Dr. Conan? Again, thank you for being here and all your service.
Yeah, just a comment. I've enjoyed being on the board. Wish I could continue, but it's not possible with the new calling. And so I want to thank everybody. I got to know more about Linda by reading about her in the paper than I did by sitting next to her. And, so I just think the board is just filled with marvelous people who intend to do great things for others. And I appreciate being part of it.
Thank you. Mary? All right. Seeing none, our next Board of Health meeting will be October 31st in the same location. And do I have a motion for adjournment?
So moved.
Is there a second? All in favor, please signify by saying aye.
Aye.
All opposed? We are adjourned. Thank you.